And without further ado, I'd like to introduce you to today's speakers, Drs. Rosanna Hess, Braxton Mitchell, and Cory Anderson. Dr. Rosanna Hess is the founder and president of Research for Health, a health-focused nonprofit organization, and is an instructor at the School of Nursing at Malone University. Dr. Braxton Mitchell is a professor of medicine at University of Maryland, where he focuses on epidemiology and where he has served as a core investigator in the Amish complex disease genetics program for the past 15 years. Cory Anderson, a man who needs no introduction at all, founder of the APSA, editor of JAPAS, the Journal of Amish Plain and Anabaptist Studies, leading scholar in the field of Amish studies, and the behind-the-scenes ringmaster of this here circus. Welcome, Cory. Thank you all for joining us today for a conversation about the state of Plain Anabaptist health research. We're looking forward to hearing about that and to learning more about the special issue that will be coming out later this year. Thank you. I'll turn it over to the presenters.
Good morning, good afternoon, wherever you might be. This is Rosanna Hess speaking, and I'd like to share my screen at some point. Natalie, can you help me do that so I can just open my...
I believe that you are also a co-host, so you should be able to have that power. You have the authority.
Okay, tell me where I need to do that share screen. I see that. Okay. Great. I might just share it even with the other slides up the side so I don't make everybody disappear. Thank you. It's been a long time coming, it seems, to get this get to this day and be prepared for this presentation. We've been working a lot on different aspects of this upcoming 2020 issue related to health. A little bit about my background. In the introduction, it mentioned that I was a founder of Research for Health, and that is an organization that I led for 10 years. And I must say that it no longer exists because it was closed. We closed it a couple of years ago. And also, as of 2 weeks ago, I am no longer employed by Malone University. I retired from teaching there, where I've been since 2002 in the School of Nursing, but I still have my hands in lots of things related to research. Some of my other background, and starting off actually with my name. My name comes from a famous book in the Amish community called Rosanna of the Amish. And my father chose that name many years ago now because of his Anabaptist connections and upbringing. And so I do have that background. It seems like some things in my life have come around again. As they say, what goes around comes around. And both of the sides of my family were Mennonite people, Pennsylvania. And now I'm coming back to actually doing some more research in that area as well as related to health issues. For many years, I was a missionary in Equatorial Africa in the country of Gabon. And in 2000, I came back to the US in 1998 and worked, as I mentioned, at Malone University in the School of Nursing since then, and mostly involved with teaching master's students research methodologies and tutoring them, coaching them through their thesis process. And then as a nurse researcher in working with colleagues, currently with colleagues who are still at Malone and some other places. I've had a bit of cross-cultural experience. I wasn't a researcher when I lived in Gabon, but I have done research there as well as in Mali, West Africa, and in Guinea, West Africa, and in the US in cross-cultural settings in Ohio, all of them actually in Ohio, mostly, yes, with resettled refugees. We have a lot in the Northeast Ohio area. with nursing students, I'll mention later, with migrant farm workers, and with the Amish. I'd like to talk a little bit about the studies that I've done with or specifically related to burn care. In 2009, I attended a seminar put on by Amish in Holmes County, Ohio, and talking about their burn care, and I found it fascinating. And then they heard I was a researcher and they had been wanting to document their work. So we got involved with the local hospital, and that became this research project and then a publication, which has been cited now by many people in several different countries. It's an article that contains a lot of details about the burdock leaf, about the B&W ointment, burns and wound ointment. And then we didn't have a big sample size, but it has produced a lot of other studies, people looking at this same issue. And we chose to put the Amish Burn Study Group as the lead author, and that has caused some confusion. People think that that group includes the following authors, but actually that group, as stated in the article, is kind of made up of Amish burn care givers who didn't want their names used, and the nurses, some of the nurses that were also involved in that group. And so that has been an influential article in this field. Leading off of that, I published another work of the process of the study, using participatory action research was our background. And so that became a case report in the Journal of Transcultural Nursing, and looked in depth at the process as well as the lessons that we learned through that process, which are listed here, and have been very interesting to see what has been accomplished because of this Amish initiated project. Research, as you know, I'm sure most of you know, research always gives us more ideas for more research. So out of that, I wanted to talk specifically to the caregivers themselves, and so met with a number of them in several states, Pennsylvania, Ohio, Kentucky, a few other states where participants came from. And I did a qualitative study interviewing them to find out what it was like to do burn care, and the types of care that they gave and the issues that they faced. And so the themes that came out of this were very interesting. You see them listed here: a rewarding work with heavy responsibility. They take this responsibility of doing burn care and post-burn care very seriously. They learned that they needed to take decisive action, but they were also, meaning they had to do something in it very quickly if someone was seriously ill from a burn. But they also were willing to wait for patients to heal. And that was the big issue of skin grafting, to graft or not to graft, is a big question that this population often has to deal with. The issue of self-reliance over and against collaboration, wanting to be self-reliant, wanting to take care of people in their own families and communities, and yet wanting to collaborate with the medical teams in the regions that they work with. And then treatment that they were not allowed to do, compared to negotiating the burn care that they wanted to do, and some eventually got to do in hospital and others not. So that was the study that was actually published in Journal of Amish Plain Anabaptist Studies in 2018. I'm currently in progress, a study that we are just finishing up data collection this month. A colleague of mine at the University, Malone University, We live in an area, if you aren't familiar with, Northeast Ohio sits between two very large Amish communities, one in Holmes and Wayne County, and one in northeast, farther northeast from where the university is, in Geauga and Trumbull and Mahoning counties, Ohio. And so we have realized in our nursing school, and it's a very important part of cultural competence of our nursing students and social work students. So we're doing a current study using the revised attitudes toward Amish scale that Cory and Ms. Ecker worked on and published, that we're looking at their attitudes. We're measuring attitudes. We hope to publish that in the coming year. My brain has thought of other things that I've listed here as possible research studies that still could be done specifically related to the burn care. I'm not specifically saying that I will do them myself, but maybe in the future, or others who would be interested in collaborating. Certainly these are open opportunities. And then I say, what do Amish and other Anabaptists want to research in the health and cultural related fields? Let's ask them what they would like to research if they're in a position of being researchers or co-researchers, or what would they want us to research? So that's my story. Natalie, I am finished.
Wonderful. Thank you so much. I might just jump in and ask the other presenters, do you want to do some question and answers right now, or perhaps we could move on to Dr. Mitchell, and then we'll save all the questions for the end. Does that work for you, Dr. Mitchell?
Yeah, that would be fine.
Oh, fantastic.
Okay, I'm going to share my screen now. Okay, can you see my screen?
Not yet.
Okay, so are my slides sharing?
I don't.
Not yet. So try again. Oh, now we are.
Oh, okay, good.
Here they come.
Okay.
Very good. Thank you.
Okay, so my name is Braxton Mitchell. I'm at the University of Maryland in Baltimore, and I've been working with the Lancaster Amish community for about 25 years. So in the next 10 minutes or so, I just want to give you an overview of our research program, the kinds of things that we're interested in. We are a medical school, so we're particularly interested in we're interested in medicine, but particularly in genetic medicine. Just a disclosure. So our research program began in about 1995. It was started by my colleague, Ellen Scholdiner. We are interested in, unlike many other groups, we're interested in studying relatively healthy Amish adults. We don't study sick kids like the Clinic for Special Children and clinics elsewhere in the country. We are interested in mainly the types of disorders that face the U.S. population as a whole. And so I've listed some of our studies, some of the topics that our studies are related to here on the left. We have our research clinic set up in Lancaster. Our research clinic includes five research nurses. We've got 8 or 9 Amish liaisons who work closely with our nurses. They go out, they do recruitment in teams, mostly house to house. We have a blood processing laboratory at our clinic, a DEXA machine to measure bone mineral density, We have a mobile van for doing home visits. And we also have an Amish Community Advisory Board that we meet with and provide updates on what we're doing, solicit their thoughts on what we should be doing, how we should handle things like COVID, et cetera. Any new studies that we want to start, we also vet through our Amish liaisons to see, is this a good idea? Do you think people would be interested in this? And we also try to tackle projects that we think the community are interested in. So one example, a new study we started about 5 or 6 years ago was on mental health in the Amish, spurred in part by interest in the community on this. So as many of you know, the Amish Lancaster community includes about 38,000 individuals. And of those, we've enrolled over the past 25 years or so, about 9,000 Amish adults, that is Amish over the age of 21, in one or more of our projects. As part of our projects, we typically do basic cardiovascular screening. We measure blood pressures, heights, weights. Depending on the study, we get a lot of other. We may get a lot of other information. We're interested in diabetes, hypertension, those kinds of things. We collect bloods to measure lipid panels and cholesterol screening, and we get DNA on study subjects. We're very interested in discovering new mutations that may be enriched in these communities. Back at Maryland, we biobank these samples to draw on as we discover new assays, et cetera. So I'm gonna, so this slide just summarizes some of our work over a number of years. So this was published last year by one of our graduate students, Lydia He. So the basic points I want to bring out of this is Amish. So these are based on exams of about 5,300 individuals. So they're not only they're questionnaires, but also these are health exams involving testing of bloods and so forth. So Amish in general get diabetes at a much lower rate than non-Amish communities. So it's about 66% less diabetes in Amish compared to non-Amish. Amish also get about half as much hypertension as non-Amish, and these are compared to the national surveys. Amish also are less likely to have high cholesterol. LDL cholesterol is the bad cholesterol that's puts you most at risk for heart disease. So Amish are at less risk of this, and this is despite the fact that there is a mutation in the Amish that causes familial hypercholesterolemia that many of you probably know about, that's highly enriched in the Lancaster community. In fact, 12% of all Amish have this mutation, which results in having very high cholesterol levels lifelong. Yet despite that mutation, Amish still get less high cholesterol. In terms of obesity, Amish men have lower levels of body mass index compared to non-Amish men, but there's little difference between Amish and non-Amish women. So in total, this points to a relatively healthy cardiovascular profile in Amish compared to non-Amish. And of course, we're really interested in trying to learn, why is this? Is this because of genetics? Is it because of lifestyle? It could be related to both, but probably it's mostly related to lifestyle. Amish, as you know, are very physically active. I'm going to show you some data in a little bit about that. How about in terms of healthcare utilization? Well, this shouldn't be a surprise to anybody in this group. Amish don't utilize healthcare services from the community as much as non-Amish. And in our studies of individuals who are diagnosed, who we've diagnosed with diabetes, hypertension, or high cholesterol, Amish are much less likely to be aware of their disease than non-Amish. And even of those who are aware, they're less likely to be treated, at least by a physician with prescription medications. Now, many of them, as you can probably envision, may be self-treating with folk remedies, but they're not in general, they're not treated very much with prescription medications. Amish are much less likely to use hospitals and the medical care system in general. So what does mortality look like in the Amish? So we did a comparison of Amish with a non-Amish group. In this case, it was the Framingham Heart Study because there's long-term data there. So this study is restricted to people that lived at least until age 30. So this is looking at mortality, given that you survived to age 30, what's your mortality beyond that? Amish are in red, Framingham Heart Study are in blue. These are survival curves so that at age 30, everybody is alive, 100% survival. And then as time goes on, people die off. And the key point here is that Amish women look exactly like Framingham women. Mortality rates in Amish, this is in the community as a whole, are exactly as what you see in Framingham. For men, Amish men actually have a little higher survival rates than Framingham men. So mortality is actually lower in Amish men than in non-Amish men. Mortality, there is an excess, as you know, at young ages, there is an excess in Amish of early mortality due to recessive genetic diseases. So these plots do not reflect that. And how about causes of death? Well, among Amish adults, the causes of death are roughly about the same as they are in non-Amish. That is, the major killers in non-Amish: heart disease, cancer, kidney disease, stroke, accidents. It's the same cluster in Amish. So Amish aren't really different than non-Amish in this regard. So I'm going to switch now and tell you, just give you a few stories about what the Amish have taught us based on some of the research that we've been doing. So as I indicated, that one of our major interest areas is in looking at mutations that are present in the Amish that you don't see so much in non-Amish. So we call these gene discoveries. We're interested in discovering new mutations. And I'm going to tell you about two different kinds of mutations that we've been interested in. The first kind are LOF, loss of function mutations with therapeutic potential. So this is a mutation that if you have it, it may actually be good for your health. And I'll give you a few examples in a little bit. The Amish have some of those. Those are really exciting because they can tell us a lot about biology, and they may even point to new therapies to try out. A second class of mutations are mutations that are enriched in the Amish, like familial hypercholesterolemia, that may have high relevance to population screening in the Amish and could potentially benefit health by being aware of these. So I'll give you a few examples of those. I'm also going to give you tell you a few lessons that we've learned about Amish lifestyle, and these particularly relate to physical activity. So one, I'm going to give you a really cool story about physical activity and a mutation that predisposes to obesity. That's in the FTO gene. And I'm going to tell you a little bit about physical activity and triglycerides. So let's do the genetics part first. This is one of the things that really excites us. So many of you probably have seen different versions of a slide like this. So this is the migration of Amish from Europe in the early 1700s to Lancaster, the first wave appearing in between 1727 and 1757, give or take. So we estimate, based on genetics, historical records, so forth, that there were maybe about 400 or 500 founding immigrants in this first wave. There are now 38,000 present-day Lancaster Amish, and all of these folks, all 38,000, are descendants of about these 400 to 500 individuals. So that means that there's limited genetic diversity. It's the same genes recirculating in here, the same mutations. So this is interesting because, so why is this community interesting? One, as I just went over, they have this unique genetics. There's this genetic bottleneck. So whatever these mutations are, they showed up over here. Some of these got lost. But then there's some mutations that were really rare back in this population, like this familial hypercholesterolemia one. And it just so happened that some of the people that came over had it. Those folks had a lot of kids, their kids had a lot of kids, and now all of a sudden the frequency of this mutation is highly increased in the Amish. This is what I mean by gene discovery. This is what we're trying to learn. But the Amish, as you know, aren't just interesting because they have unique genetics. They're also interesting because they have a very unique lifestyle. So a couple quick stories on some of the gene discoveries in the Amish. So the first class, genes with therapeutic potential. One of my colleagues, Tony Poland, about 10 years ago, identified a mutation in this gene called ApoC3. So what does this mutation do? Well, this mutation blocks the function of this gene, and it stops the inhibition of an enzyme. This enzyme is called lipoprotein lipase. Well, what does this enzyme do? This is an enzyme that breaks down triglycerides. So if you can no longer inhibit this enzyme, it means that you continually break down triglycerides all the time. As a result, you end up having very low triglycerides levels. And subsequently, this has been shown to be cardioprotective. This mutation has a frequency of about, I think it's about 3% in the Amish. It has since, after the Amish, it's since been discovered in other populations, but it is really, really rare. And why is this exciting? Because, gee, if you can develop a therapy that stops this gene from working, that might be a great therapy to help prevent heart disease. And not only that, it's not just in the Amish. This therapy would be good for anybody. So, and in fact, there are now ApoC3 inhibitors being worked on as a heart disease prevention medicine. More recently, so that's one example. More recently, there's a gene called B4GALT1. We've discovered a mutation. This is my colleague May Montasser. Just recently discovered a mutation in this gene that's associated with having very low LDL cholesterol levels. Well, that's really exciting. That could be another target, because develop a therapy that interferes with the function of this gene. By the way, it's a lot easier to develop a therapy that interferes with the function of a gene than that tries to restore something that's wrong. So we don't really know exactly how this gene works and how it's affecting LDL levels. That's what we're trying to work out now, but it's a very exciting discovery. So these are, there are a few other examples, but these are genes that have mutations that have therapeutic potential. as you can envision, we've also identified a number of founder mutations that are enriched in the Amish. And some of these are associated with treatable conditions. Not all of them, but the ones that are associated with treatable conditions are really exciting because they offer the possibility that we could actually do something good for the community for their service in participating in our studies. One of these is in a gene called ApoB, and this is a known cause of familial hypercholesterolemia. There are lots of different mutations in this gene and in several other genes that cause familial hypercholesterolemia, but this particular mutation is really highly enriched in Amish. 12% of all Amish have at least one copy of this mutation. You have very high cholesterol levels all since birth, and if you don't do anything about it, you end up dying early of heart disease. But the good news is that if you are diagnosed with this early and want to, you could go on lipid lowering medications that would bring these down and maybe lessen your risk of heart disease. So this is one mutation that's highly enriched in the Amish. A second one that we discovered about 5 years ago is in a gene called KCNQ1. This mutation is a cause of long QT syndrome, which is an arrhythmia in the heart. If you have this mutation, you're at risk for sudden cardiac death. About 1 in 45 Amish have this mutation. This is highly enriched in Amish compared to non-Amish. But the good news is that if you go on beta blockers, this will greatly minimize your risk of arrhythmias and sudden cardiac death. So one of the areas that we're exploring in the Amish now is we're very interested in people's interest for getting screened for these variants and trying to incorporate this into practice of medicine within the Amish communities. Okay, lifestyle and health in the Amish. Physical activity levels, as I'm sure you all know, are much higher in Amish than in non-Amish. In the Amish, high physical activity levels are associated with lower triglyceride levels. And what I want to show you now is I think one of my favorite studies that we've done over the years in the Amish. And by the way, we were able to do this by measuring physical activity very accurately using these Actical sensor devices that about 800 of Amish participants wore for a week. So we had a week's worth of quantitative physical activity measures in the Amish. So I'm going to take you through this slide really quickly. In 2007, there was a really exciting publication in the genetics world about a mutation in this gene called FBO that was associated with obesity. So like everybody else, this mutation is common. It's about 20% of adults are carriers, 20 to 25%. So like all the other groups in the world, we quickly screened the Amish to see if they had it. And of course they did, like everybody else. Wasn't particularly enriched. And this just shows body mass index levels if you don't have any copies of this mutation. If you have one copy, your BMI level goes up a little bit. If you have 2 copies, it goes up twice as much. It's a big effect size. One copy drives your body mass index up about a half of a BMI unit, or almost a pound, about a pound. So the question we were really interested in was, gee, what if you have high physical activity levels, does this blunt the effect of genetic risk of obesity? The answer is yes, it does. So in a neat analysis that this is one of my postdocs did a bunch of years a while ago, is we divided our 800 Amish participants into two groups, one with the lowest, the half with the lowest physical activity levels, the half with the highest physical activity levels. In the lowest physical activity levels, here's what you see in every other population. If you this variant, if you have this variant, it drives up your BMI levels. But look what happens if in the high physical activity group, there's no effect of this variant. So this really teaches us, I think, a really important public health lesson that we probably, many of us probably guessed at anyway, but lifestyle often blunts the effects of genetic susceptibility. So if you're genetically susceptible to diabetes, obesity, hypertension, but you have a healthy lifestyle, you can really minimize the risk of your genetic susceptibility. So great lesson that the Amish have taught us. And subsequently, about a few years later, this other big paper got published showing essentially the same thing, except they had a sample size of 218,000 individuals in their group because they did not have very good measures of physical activity. It was by questionnaire, and this was combining data across a whole lot of different studies. So what are we doing now? Well, for genetics, we're very interested in callback studies of some of the newly discovered variants that we found, where we're trying to figure out what do these variants do. So we're calling back these individuals and their family members to do different phenotyping to try to get a better idea of how this variant affects biology. We are returning genetic results of some of our variants where knowing about these variants can actually impact your health. We're offering screening of these variants to family members. We've also started a new study where we're expanding gene discovery to additional Anabaptist cohorts, including in Holmes County, Elkhart County, Geauga County, and in Pinecraft in outside of Sarasota. So this study is just getting underway, and our goal is to recruit about 8,000 individuals over the next 5 years. For population health, we're very interested in the relation of reproductive health and long-term cardiometabolic health. We're interested in the genetics of mental health. We're very interested in social epidemiology, things like how does the fabric of the Amish culture and the idea of very close community connections, how does this affect health? So some of the challenges to the field that we and others I know are grappling with are, what are the best ways to implement genetic medicine in the Amish? What are some of the barriers to healthcare and access to healthcare? What do Amish what would they like to have? What would they like to see? And what are we able to do? And what is the relation of Amish culture to health? So with that, I will stop and turn this over to Cory.
Hi, everyone. Excuse me. Thank you for coming today. I am excited to see this special issue of JAPAS focusing on health and culture get off the ground. And I'm extremely grateful to both Rosanna and Bracky for being willing to take on guest editorship of this special issue. As you've heard from both of them, I think they both bring this unique set of skills and backgrounds and accomplishments to this special issue. I'm just amazed at the research program that the University of Maryland has been pulling off the past 20 years at least, and all of the individuals that have been recruited and some of the very strongly quantitative findings that they're developing. On the other hand, I've been very impressed with Rosanna's qualitative work and her engagement with Amish individuals to collectively together through collaboration solve problems that they're interested in. So I think as co-editors, they really bring together these valuable skills in the issue. And I hope if you're thinking of bringing a submission to them, that you'll also agree that they are going to be well poised to lead out in this special issue on health, which we have not seen a special issue on health and plain people in any journal since I think the late 90s. So it's really time to bring together different voices into conversation with each other and take steps forward. My interest in this subject came out of both a work with an undergraduate student at Truman State University, where we were working to synthesize all of the literature about the Amish and health, and then also a postdoctoral position that I took at Penn State in population health and social environments. I am putting in the chat the 3 articles that have thus far come out of that effort with the undergraduate student. And the discussion I'm going to have today basically is a summary of the discussion section at the end of each of these 3 articles. I've just tried to consolidate it into one location. I think I put my slides into the chat. Did those come through earlier on? I didn't mean to send them so soon, but it looked like they just went. I'm just going to resend them just to make sure. Did that come through in the chat? Rosanna says yes. Great. So rather than pulling up share slides, you've got my slides. You could refer back to these things. This is just, I don't know. We just went through Christmas and then I had a birthday, and it's a gift time of year in my thinking. So this is my gift list for what I think would really help advance our understanding of the dynamics between Amish culture and then health outcomes. I will just go through these speedily, and then you could refer back to them if there's any questions or points that you want to follow up on. Even though I can't imagine that we're going to accomplish all of this with a special issue, I still am hopeful that researchers could take a moment to at least ponder some of these new questions and think in new directions, and maybe even like qualify their studies a little bit more, and perhaps see opportunities coming out of these recommendations in their own studies. First, I really hope to see increased attention to this intersection between cultural explanations and health practices and outcomes between the plain people. We've seen more in-depth research on the health culture, and we have impressively quantitative studies about health outcomes and health practices, but it's rather unusual in all the studies I was reading to really find this nice intersection of both theory and practices and outcomes. We kind of take this assumption that just because we see some sort of differences between Amish and non-Amish, whether in cultural practices or in health differences, that those two are necessarily related or somehow causing each other. I think we need to investigate that assumption a little bit more. And one way to do it is by not taking the identity of Amish as the total identity of every individual. That there are different nested levels of identity among the Amish that influence the ways that they practice health or health outcomes occur. Both identities beyond Amish and also within Amish. Recommendation number 2 is that we should engage theory and theory shifts. I've noticed a little bit of a debate that got kind of sparked up, especially around Helen Farrar's research on Amish aging that was published in the past several years, between cultural competency as an approach for understanding Amish health versus cultural safety. Cultural competency is the most common approach that we've seen since the 90s, and there have been so many articles published on Amish health that have taken the cultural competency approach, where if we could just understand the Amish culture better, then we are better poised to provide culturally competent healthcare. However, this introduces several problems. which I have in these slides, 4 problems. One is that there are inconsistencies in taking this approach between a local context versus just inevitable generalizing. Cultural competency doesn't want to generalize, but in the end, they end up generalizing often because they provide tips for best practices, which are then difficult to curtail into how widely you apply them. I'm also concerned about cultural competency sort of othering the Amish as this novel group, whereas we are the normative people who are looking on trying to understand them. Third is sort of this desire to explain away everything. If we could explain how the culture impacts health, then everything we find about the culture is in some way going to impact health. And I don't know if that's necessarily so. Finally, it neglects questions of power relationships, both between Amish individuals and between Amish and service providers. That is what the cultural safety approach tries to address, but this debate has barely even gotten off the ground. 3 is an encouragement to reevaluate outreach programming. Many health outreach assessments are looked at once and then never looked at again for the long term. There are several exceptions, but I think we need to go back and see if outreach programming is effective and for what length of term. 4th, I'd love to see more interdisciplinary collaborations between people who are much more engaged in the physical health sciences and those who are much more involved in the humanities and the social sciences. I think there's a lot to discuss across those camps. 5, we've got a lot of little studies. I say little studies, a lot of focused studies on particular areas with a particular research question, but we've got hardly any replication studies to see if what we're finding in one place in one time is actually what we're finding in another place at another time. So ultimately, I read a research article and then I'm left wondering, how applicable is this to all Amish everywhere? And why should it be applicable? So some of our conclusions then, a lot of what we think we know about Amish and health is just based on one place and time. Replication studies are easy to do, but unfortunately, they're not very rewarding if you just kind of find similar results. So we need a little bit more incentive to do these replication studies. 6, I think we should revisit some of our methodological strategies, especially look more at the reliability of self-report data versus clinical evaluations. There's been very few assessments of that. And if we're dealing with supposedly a quote unquote other culture, then there's a lot of question about the reliability of our data, either from the angle of what's self-reported or from how things are interpreted in clinical evaluation. I think we also would benefit from longitudinal studies that look at health patterns over time. 7, we're missing some very important explanatory variables that predict health outcomes in other populations. Why are these missing? Namely, we don't really take measures of educational attainment. We kind of assume Amish stop at 8th grade, therefore it's controlled for. I think there's other measures of educational attainment among the Amish besides that we could be looking at and inquiring about. Educational attainment is associated with health outcomes in many other populations. Why do we hesitate to explore it in ours? Is it due to lack of data or just assuming too much about that 8th grade cap? Second, class differences. There's been very little research done about the Amish and social class differences, but we do have evidence that social class differences are increasing within the Amish. And social class differences are one major predictor of different health outcomes in other populations. But we've hesitated to probe that so far. Third is healthcare access. And finally, prejudice and discrimination, which is perhaps still in its fundamental research stage. Why, how are Amish discriminated against, or is there prejudice against them? Does that always have to be negative, or is there also positive prejudice and positive discrimination, which could actually negatively impact health outcomes? I'm thinking especially of the parallel between what's called the model minority myth of Asian Americans and how that expectation for them to be perfect in some realms actually puts a lot of pressure on them to perform in ways that they may fall short of and get double penalized. And then I had a ninth recommendation, which is, eighth recommendation is to develop in-depth literature reviews of individual subject areas. I tried to do very broad coverage, but I'd like to see much more in-depth, maybe even like systematic rather than just narrative reviews of the literature topics. And finally, revisit a few declining research cluster areas, which I guess everyone can decide what their favorite picks are. So that's a little bit of my dream list, a little bit of the vision of what prompted this interest in triggering a special issue on health. And I'm just very grateful that both Bracky and Rosanna have stepped up and are willing to take this on. I'm really looking forward to the types of conversations and new findings that we may have coming out of this issue. We are, of course, looking for empirical studies, but I think we very much would invite some reflective type of essays. And then, of course, research or reflection essays coming from plain people themselves and providing their perspectives. We've had two very interesting essays the past several issues from plain people, one by Michael Souter in volume 8, issue 1, where he's looking at why plain people seem to prefer insider networks of knowledge versus the established scientific knowledge. And then we just had another very interesting essay from Philip Martin in our agriculture issue just published, where he was looking at ag extension agents and some of their work with the Amish and Mennonites over the years. So some of those are I find some of the most interesting insights are those articles written by plain people who are curious enough to pay attention to what's going on in academia. With that, it looks like we're running a bit low on time. Let me turn the moderating back over to Natalie. Just a reminder that articles are due in early June, and we do encourage you to connect with Bracky or Rosanna or myself if you wish about anything that you're thinking of submitting.